Albert's panicking, because when I sent him my thing, he's like, you know you only have 10 minutes, right? I'm like, yeah, no worry. Small, like, quick statements per slide. So he was like, huh. Okay. So we weren't really sure. We got a little confused on what we were supposed to present on. And we thought, first we thought it was data, then we thought, then there was something about early intervention. So we're like, okay, what? But then I thought, well, I'll take this opportunity to share about early intervention because we're such a small population, and like with all these big systems, we're like this little itty bitty piece. So not everybody is as familiar with early intervention as with everything else. So, next slide. So everyone's familiar with Public Law 94-142, and way back in 1975, we put in place services for school-age kids with special needs. So when it was reauthorized in 1986, this is when they put in place for early intervention, for providing services for kids birth to age 3. So I just wanted to let you know that. Back then it was considered Part H services, we are now considered Part C services. So you hear Part C, early intervention services, and that's what we're talking about. So we're operating right now under Public Law 108-466 that was passed in 2004. And we have our Hawaii Administrative Rules that was just recently passed in 2015. Next. So this is a partial organizational chart just to show where we fall. So we fall under the Department of Health and directly under the Children with Special Health Needs branch. Next. So every state has to identify their lead agency. So in Hawaii, Part C, Early Intervention Services, falls under the Department of Health. So other states fall under Department of Education. So every state varies. So, and the Department of Health identified the early intervention section as the section responsible for the implementation of IDEA Part C services. So, and then we have our state early childhood services programs, we have contracted programs, and we also have fee-for-service providers. Next. Anyone can do a referral into early intervention. So if anyone has any concerns about a child's development, they can call our early intervention referral line, which was formerly known as HKIS, and they would forward the referral to our developmental programs in where the family lives. For the neighbor islands, because we only have one program in the neighbor islands, a lot of times they will just receive direct referrals from the referral sources, which works too. And if they don't know, they can also call our EI referral line too. Next. So nationally, there's a mission statement about Part C services, and really what it's saying is that Part C early intervention provides supports and resources to assist the families and the primary caregivers to enhance the child's learning and development. Next. We have 2 eligibility categories, which is development delay and biological risk. Next. So a child is found eligible if they have a significant delay in one or more of those following areas. And in October 2013, we changed our eligibility criteria. So before a child had to have a -1 standard deviation in any area. Effective October 2013, it changed to a -1.4 standard deviation in at least one area, or a -1 standard deviation in at least 2 areas. We are still nationally considered to have a broad eligibility for our kids. And we use the Battelle Developmental Inventory tool, which is our standardized tool to determine eligibility. Next. A child may also be found eligible if they have a condition that has a high probability of resulting in a developmental delay. So we get the diagnosis from a doctor, a physician, or a psychologist indicating the condition. Next. So looking at our enrollment and our numbers, so it looks like we are serving more kids, but actually we found less kids eligible, and that was due to our change in our eligibility criteria. So the blue is the number of developmental evaluations we did, and the orange is the amount of kids that we found eligible. Next. If a child is found eligible, then these are the mandated services that we provide at no cost to the family if it is determined that the child and family needs these services and is listed under individualized family support plan. Next. So in looking at the services, our utilization of services, so if you look, the purple is the highest, so that's speech language pathology services. So most of our kids are receiving that service. And if you look at the small, which is the blue, that's our intensive behavior support services, which is 6% of our population is receiving those services. Next. And then looking at the cost of what those services cost us. So if you look at the IBS, which on the previous slide, it was our smallest portion, which is 60% of our population, but it's also our most costly service that we provide, and understandably so because it's more intensive services that they're receiving. Next. This is just real quick just to say we followed our family-centered care principles when we're delivering services. So basically we're recognizing that families are the constant of the families in the child's life, and so we must respect and partner with them in providing those supports to them. Next. Every child that comes into our system has a care coordinator to help navigate them through our system. Next. In addition to our developmental evaluation, we also do a family-directed assessment so that we can work with the family to help identify their resources, their priorities, and their concerns so that we're in a better position to help provide the supports that they need. Next. Our service is provided within the natural setting, which means that we provide services where the child lives, learns, and plays. Next. We utilize a primary service provider model, which means that we identify one person on the team that will implement that individualized family support plan and provide supports to that family in conjunction with consultation from the other team members. Next. We also use our coaching model, which means that we're in there to help enhance the parent or caregiver's abilities to meet their child's needs. So we go in there and coach them and work with them instead of us coming in as the professional and we do everything and telling the parents what to do. So we work in conjunction with the family. Next. So we do transition kids out of our system because we only provide services up to the age of 3. So we work with the family from the get-go because they're in our program for such a short amount of time. So we're always talking about transition and that they will transition out and we will help support them through that transition process. Thanks. So when we are transitioning them, a lot of times they go to DOE special education preschool or Head Start, private preschool, play groups, childcare, community recreation groups, and sometimes they go home. Next. So we know that we can't do it alone, and we have to collaborate and work with a variety of different agencies to meet the needs of all the kids and families that we serve. So we try to network and collaborate with like Early Head Start or CWS or any other program that's working with the family. Next. So this is nationally the Early Childhood Mission Statement. So which is that we want in Part C to enable young kids to be active and successful participants during the early childhood years and in their future in a variety of settings, in their homes, with their families, in childcare, preschool, and eventually school, and in their community, which is cut off on the slide, sorry. And then this is more specific to early intervention. So these are our outcomes that we have for the kids in our program, which is for kids to have positive social emotional skills, that they learn and use knowledge and skills and they take action to meet their needs, and also for families, that we're helping families know and understand their rights and effectively communicate their children's needs and to help their children develop and learn. So these are outcomes that nationally all Part C programs are collecting data on. And we collect it at 2 entry points. We're collecting it at when they first enter our program, before they receive services, and then when they're exiting our services, to really see, are we having a positive impact on the kids and families that we're serving. Next. So what we include in the HIPAA report, so how are we doing with child outcomes? And so you have the 3 areas, like I explained. And if you look, then the lowest area right now, or the area that we're not doing so well in, is positive social emotional skills for kids. So, you know, Dr. Michaels talked about how we want to move from compliance to more outcomes and result-driven accountability, which we have to report on this to the Office of Special Education Programs. So we've been tasked now to start looking and developing a state systemic improvement plan. And we had to identify one area that we wanted to focus on. And so the child outcome area that we are going to be focusing on is our positive social emotional skills. So we're going to look at our whole system and what do we need to do to improve our system so that we can have more positive outcomes for the kids in this area. Next. And then this is just a look at our family outcomes and how we're doing with families. And this is, we gather this data via a family satisfaction survey. And so we're doing better. We've made improvements in that area. Next. So, and we just always try to remember that it's all about the family, and we're here for the family. Thank you.